I believe we're waiting on just a few more members in order to meet quorum. Good afternoon, everyone. Thank you, everyone, for joining us. This is our first official work meeting for the task force to study methods to address the shortage of radiologic technologists, nuclear medicine technologists, and respiratory care practitioners in the state, and to develop a plan to address that shortage. Just to review our charge, the task force is charged with reviewing workforce development issues for radiologic technologists, nuclear medicine technologists, and respiratory care practitioners, and a report to the Public Health Committee is due January 1st of 2025. My name is Bernadette Mealy. I am one of the co-chairs in association with Matthew Green. So right now, I am going to turn it over to Matthew for his report from the nuclear medicine technologist.
All right, hello everyone. Thanks for joining. So we're just going to follow the agenda and kind of go through. I'll try to share real quick. Can we all see that or no? No?
No.
Yeah. There you go.
Still
Yeah,
no?
see it. No. I
It
can
was
see it now.
working.
Yeah.
Okay. So just I just threw a few slides together, kind of just go over the background. A nuclear medicine technologist performs tests for diagnosis and medical research. They work in hospitals, outpatient settings. They use far more radioactive drugs. They inject them into patients. They use high-level imaging equipment to record images of those radioactive material in the body. We use physicians who interpret these, study and diagnose an infection or disorder. Nuclear medicine technologists can also give doses of radiation to patients and internally treat medical conditions. To become a nuclear medicine technologist, one must graduate from an accredited nuclear medicine program with an associate's degree, where they can receive a certificate with an approved associate's degree, meaning they have an X-ray degree, another degree on top of it that the accrediting bodies see as adequate, and then they take a certificate program on top of that and then can sit for the boards. So a nuclear medicine technology program prepares students for employment as a nuclear medicine technologist, hospitals, medical offices, outpatient ambulatory clinics. The accrediting bodies, after they complete this program, they can sit for 2 different exams in Connecticut, American Registry of Radiologic Technology in Nuclear Medicine, or the Nuclear Medicine Technology Certification Board exam. To be able to sit for this, they must complete an associate's degree or the certificate program from the Joint Review Committee on Educational Programs in Nuclear Medicine. Through these, the Nuclear Medicine Technology Certification Board only accepts examinations through accredited nuclear medicine technology education programs. And to sit for the AART Nuclear Medicine Technology exam, one must have an associate's degree from an accredited nuclear medicine program. I was kind of joking with Bernadette. My task to find the programs in Connecticut and report on the numbers was slightly easy because there is one that offers nuclear medicine technology program, and that's Gateway Community College. So for numbers, you can obviously see them. They offer associates and a certificate program. It takes about 22 months of clinical and theory education to get this associate's degree. They have a capacity of 16 students. For the available data was for a 2-year period of 2020, 2022. They had a graduation rate of 44%, and they had a registry pass of 88%. This is a total of 16 exams, and this was a combination of both the exams that we talked about earlier. And that's what I have.
Thank you, Matthew. So yeah, he had nuke med techs. I am going to be reporting out on the radiologic technologists, which is a little bit more extensive than what we had there. So what I'm going to do is I'm just going to share.
Can I just do, we're gonna ask, I have a question about the nuclear medicine, but I don't want to interrupt the flow if you want to do.
Sure, go ahead.
Sorry about that. So Matthew, I was interested, did Gateway have the information about how many were associates versus certificate of those slots? And does certificate take, I'm assuming the certificate does not take 22 months like the associates does, or is it the same amount of time for each?
Yeah, so the AART actually, they spell it out better where they have like a primary path, and that's your associate's degree. You go right in, that's a primary path. That's how you start and finish to be able to sit for their exam. The secondary path's a little more convoluted where you would have an associate's already, meaning you go to like an X-ray technologist school, and then the certificate you get on top of that. I don't want to assume anything. I assume the certificate is a shorter length. But they didn't have any readily available information on their website. I had reached out to their program director, and I haven't heard anything back. A little more.
Maybe we can just put a pin in. My thought was we have, to the extent we have individuals who have a associate's degree in a different discipline, and the certificate program could be offered not just at community colleges, but I know we have other like workforce investment board programs that offer some certification programs. Wondering if there's an opportunity there down the future, just given there's only one right now offering, if there's an opportunity there. Okay, I appreciate it. Thank you.
Great, thank you. Thank you, Paul and Matthew. That is definitely something that we can consider. Bear with me while I move my portion of the screen. All right, are you able to see that okay? Yes, okay. So my portion is about the rad techs in the state. So just to give an idea for a background for radiologic technologists, that is the entry level is radiography for our program and for our profession. The credentialing body for the profession is the American Registry of Radiologic Technologists, so the ARRT. They support 15 credentials. Of those, they range in different pathways and different disciplines. The pathways themselves share the same ethics, but they're and exam requirements, but they have different educational requirements. So if you're in the primary pathway, such as radiography, that's what I'll be focusing on today. You also have primary of radiation therapy, MRI, nuclear medicine, sonography, and vascular. You have to have earned an associate's degree or higher, completed an ARRT approved educational program in the same discipline as the credential that you're pursuing. And the degree has to come from an institution that's accredited by an agency that the ARRT recognizes. It does not have to be a degree in RS, but it has to be earned before or after graduating from an RS educational program before the registry exam can be taken. Post-primary can be taken once the individual has been deemed qualified to perform any of these categories. So that would be bone densitometry, breast sonography, cardiac interventional radiography, computed tomography, magnetic resonance imaging, mammography, vascular interventional radiography, vascular sonography, as well as the registered radiologist assistant. So with that, we give us a little bit more information. So I had 8 educational programs in the state of Connecticut. So there are 5 out of the Connecticut State Community Colleges, and then there's 3 private universities. So the degree offerings vary. Associate's level is the minimum degree that you need to be able to enter into the field. So there are 6 that offer associate's degree and 2 that offer bachelor's degrees. 1 is a 3-year program, 1 is a 4+ program, and a certificate. So other post-primary, so anyone that's going into computed tomography, MRI, or any of those other categories can have different ways of learning. So training on the job, post-radiography certificate programs, online self-directed education, or a graduate degree that's combined with leadership. Regardless of the pathway that you choose for a post-primary after X-ray, you have to document 16 hours of structured education and complete clinical experience per your modality. So the programs that we have, so out of the state community colleges for Connecticut, you have Capital, Gateway, Manchester, Middlesex, and Naugatuck, and they vary anywhere from 20 to 21 months, 20 to 22 months. So the capacities here might be different, but these are the ones that are listed on the joint review Committee on Education, so the JRC. So for capital, the capacity is going to be total 40, so that would be 20 per cohort. For Gateway, it's 72 capacity, so that would be split in half, so 36 per cohort. Manchester would be 22 per cohort, Middlesex would be 24 per cohort, and Naugatuck would be 23 plus per cohort. Quinnipiac University is a 36-month program, and at that, they come out with an associate's, with a bachelor's degree, a 3-year bachelor's. The capacity there is 96, so that would be 33 per cohort. Sacred Heart is a 24-month associate's, so that would be 40 per cohort. And then University of Hartford has 2 designations. So altogether, they have a capacity of 58, so about 24, 26 per cohort. Their program is a little different. So at the end of the 3rd year, they get an associate's degree, then go on to specialize and will go on and get a bachelor's degree at the end of their 4-year. So the completion rate for radiography, out of the community colleges, Capital has a completion rate of 60% for those that they enter into the program. Gateway is 100%, Manchester is 100%, Middlesex is 87.5%, Naugatuck is 66%, Quinnipiac is 95.65%, Sacred Heart is 45%, and University of Hartford is 76%. 5-year pass rates vary as well. So they range anywhere from 77.1 all the way to 95.86. So Capital is a 92% pass rate, Gateway is an 86, Manchester 91.2, Middlesex 95.86, Naugatuck is a 91. Quinnipiac's 89, 78% for Sacred Heart, and 77.1 for University of Hartford. And this is an average over the 5 years. Placement rates are pretty good. So anybody that sits for the registry, completes the program, and passes the program, they will then be pretty gainfully employed. So we have about between a 97.5 to 100%. And some of that can be attributed to students that go on to graduate school afterwards, so they may not be working, but most of them are working post-degree. So the results themselves, when we think about it, so your capacity, the completion, so based on the pass rates and the placement rates, from those that pass their registry exam, 99.44% will gain employment. From the number of eligible students who complete the programs in Connecticut, 87.26 pass their registry exam. So if we were at capacity in all of the programs each year, we should have about 153 plus techs that can be employed at the end of that time period. Some statistical information. So in the state of Connecticut, there are 4,358 licensed state radiographers. Of that number, 4,191 hold ARRT credentials. And out of that number, those techs also have dual credentials. So they have multiple credentials in addition to that. So in Connecticut, we have ARRT credentials for about 3,820 technologists, 135 nuke med. As you can see, I don't need to read the numbers to you. You can see the numbers here of the different specialties, but most of these or all of these will have that Connecticut radiographer licensure. They might not work in X-ray or radiography alone. They may go on to specialize. So that is my report for radiography. Are there any questions that I can answer?
A little bit. Bernadette, do you know, and maybe Matthew too, I didn't ask, did the colleges report that the programs were fully subscribed and that they were turning people away, or are there seats available? I know in nursing, it's one of the issues we're facing, which is like it's a fully subscribed program and you have to say no to folks.
So they don't, not that I'm aware of. I'm not aware of that number being posted anywhere or publicized. I can tell you just from my own personal knowledge that there is a high number of applicants for all of our radiography programs.
I know for a fact just that University of Hartford is way over. We can't take close to how many people are applying for the radiology technology program.
Yeah, thank you, Karen. And I believe that is the same across the board. I think it is all throughout.
Okay.
All right, so now I'm going to hand it over to Karen and Raja, so for a respiratory care practitioner's report.
Can you see my screen? Okay, so Sajad and I are going to kind of tag team this. We worked on it together. So I'm just going to move on to the next. 1 second. There we go. So Sajad's going to start by just talking a little bit about what a respiratory therapist does.
So just to summarize the role of the respiratory therapist, we play a critical role in patient care. We work with patients of all ages, from premature infants to the elderly. It is a specialized healthcare where we're trained in pulmonary medicine in order to work with patients suffering from all kinds of pulmonary disease. Our most common responsibilities are assisting with diagnosing lung and breathing disorders and recommending treatment, managing ventilators, artificial airway devices for patients who can't breathe normally on their own, consulting with physicians to recommend a change in therapy, analyzing breath tissue and blood specimens to determine levels of oxygen, carbon dioxide, other gases, responding to cardiac alerts or code blues and other urgent care calls for care, and then educating patients and families about lung disease.
And then in addition to this, we didn't put this on here, respiratory therapists, kind of like radiology technologists, can get additional certifications, and they may work in different areas as well, but we left it to more of the common responsibilities. So I was going to talk a little bit about how bad the workforce shortage is. And, you know, we all have workforce shortages, and we talked about last meeting how the workforce shortage could be due to different things for different professions. But some of them are going to be the same, right? So the aging population, that's one of the big reasons why we have a workforce shortage. There's more respiratory disorders and therefore more need for respiratory therapists. There's advances in pulmonary technology. ECMO is a big one. We have respiratory therapists who are now sort of getting pulled from regular respiratory workloads to man the ECMO machines. With the aging population, there's more diagnostics, there's better diagnostics. So one of the specialties is pulmonary function tests and different diagnostics. And then we have our retirement is outpacing our graduating RTs. So national data, and I pulled this from our 3 national organizations, AART, American Association for Respiratory Care, COARC, which is the accreditation agency, as well as MBRC, which is our credentialing agency. But there's currently 140,000 RTs in the US, and this is nationwide, more than 93,000 are expected to retire or leave the profession for other reasons by 2030. There's been a 27% decrease in respiratory therapy programs, and only 10% of respiratory therapy programs across the country are filled to capacity. I have specific numbers on Connecticut. There's 0 programs in Connecticut that have been filled to the capacity for the last 3 years. 93% of respiratory therapists say that burnout is a major issue, and Sajad's going to talk a little bit about that on the next slide. 19% growth rate for RTs is estimated by 2029. And we have 100 million Americans affected by respiratory disorders. So this isn't going to get better unless we figure out ways to solve this. And then Sajad.
So I'll briefly go over this slide, and then we'll move to the next slide because that's the one that has some data that I want to go over. But the real cost of respiratory workforce shortage, there was a study done in British Journal of Medicine that discusses how patient healthcare can be affected by reducing the number of respiratory therapists. This was published in May 2022. But the other 3 issues, and ones that I've experienced personally, increased workloads, meaning the amount of work per respiratory therapist has increased significantly over the past 4 years since COVID, increased hospital costs, including overtime, travel positions, not to mention, because we have a higher volume of patients, that also includes more money required for equipment, which would also then mean more money required for respiratory therapists to manage that equipment. And then, of course, burnout due to high workloads.
Do you want me to go to the data?
Yeah.
Okay.
So this is just some information that I was able to get from Hartford Hospital and Hartford Healthcare. So each graph is a comparison from fiscal year 23 to fiscal year 24. We're looking at, starting at the top left, the respiratory vent CT scan volume. So the amount of CT scans that patients require who are intubated and not on a mechanical ventilator, it's already out for every month this year. We've been outpacing 2023. If you go over to the next slide in the top right, respiratory non-invasive volume comparison. Again, aside from December of last year, on track to outpace fiscal year 23. High flow volume comparison in the bottom left, which is high flow nasal cannula, high flow oxygen. Again, already on track to outpace 2023. And then the metric that affects me the most, because I work in an ICU, at the bottom right, that's
I think, I apologize. I think I put the wrong one on there. That should have been the transport. So, and that was also equally as high. Yeah.
So the number of patients who are requiring mechanical ventilation, again, since 2023 is on track to outpace 2023, or 2024 is on track to outpace 2023. So we have real-time data showing that workloads are only getting higher. And so there is a immediate need for more respiratory therapists in the field.
Thank you. So then how do we become a respiratory therapist? And a respiratory therapist, you have to graduate from an accredited associate or bachelor program. Our national accreditation agency, COARC, accredits both. You can sit for the board exam, the national board exam, if you have graduated from an accredited program, either an associate or a bachelor's. Once you graduate, you can sit to take the national board exam. Our national board exam is a two-part. The first part is called a TMC, Therapist Multiple Choice Exam. If you pass that with the low cut score, you become a certified respiratory technologist and you can work in Connecticut as soon as you get your state licensure. If you pass that with the high cut score, then you can go on to take the second board exam, which is the CSE, the computer simulation exam, and then you can obtain your registered respiratory therapy credential. Either path, and we encourage everyone to become an RRT, that's the higher level. Either path, you still need to get state licensure, and then you need to continue with your continuing education credits. We have 5 entry-level programs in the state. That means that they make respiratory therapists, and then when we have 1 degree advancement program. So there are, out of the 5 entry level, 4 of them are associate and 1 is bachelor's. So an entry level bachelor program and 4 entry level associate programs. And then we have 1 degree advancement. So they take graduates who are already working respiratory therapists and help them get their bachelor degree. So out of those programs, just some of the data that that we were looking for. Graduates, this is all this data. So they get data on the last page and this page is from our COARC, our accrediting agency. You can get the data right off the website. And this is also from that website, from the data there. So this is 2020 to 2022. For Goodwin had 29 graduates in that year. University of Hertford had 25, Naugatuck Valley 37, Norwalk 33, and Manchester 34. Our accrediting agency only has everyone report on the high cut score. So there could be people who are graduates who are getting the low cut score, and I don't have that number because it's not something that's reported on at this time. But the high cut score, everybody in the state of Connecticut was over the COARC threshold of 60%. Good, and you can see the numbers: 76%, 86%, 89, 91, and 97. The attrition rate, based on our credentialing standards, and the threshold for our credentialing agency is 70%. Our average attrition rate over the state is pretty high. We range between 60 and 100%. But I think the real numbers are in this right here. And I think, we talked about that different issues for the different professions. This right here shows the issue for respiratory. We are not filling our seats. None of the programs are filling the seats across the country in our state. And I think we really need to target high school students. We need to target people to let them know that here is a great profession. We're making a good money. It's exciting work, and we're still not filling our seats. So I'm going to go through these programs. I put Southern on here for completion's sake. This was not on the cohort because it's not on a, they're not an entry-level program. That was a self-reported from the director of Southern University. But out of the entry-level programs, we have a 59% capacity. The max enrollment for Goodwin is 40. Over the last 3 years, they were at 38% capacity. University of Hartford, the max enrollment is 18, and we're at 41% capacity. I apologize, this should say for Naugatuck Valley 20, and they're over the last 3 years is at 85% capacity. Norwalk, the maximum enrollment is 20, they're at 53% capacity. And Manchester, the maximum enrollment of 20, they are at 78% capacity. And again, for 59% overall for all the entry-level programs in the last 3 years. And then one of the things we had talked about the last meeting was to think of ideas to help with shortages. And Sajad and I have been meeting with different people at the state level. And so some of the things that we have are loan forgiveness. Really, we need to help people to recognize that this is a profession, and then to help people who might not have been able to afford education to pursue this degree. So we would like to hopefully get on the loan forgiveness under the Lamont bill. Our national organizations are really trying to push for all the respiratory states and programs to support HOSA, which is Future Healthcare Workers of America. Connecticut has over 30 chapters. We just don't have a lot of support. To me, this is a low-hanging fruit. There's a lot of high school students that are in HOSA that want to participate. And there's just doesn't seem to be enough money to have a real thriving program for HOSA. A lot of them want to come, but can't afford buses, simple as that. So some support for HOSA, grant money for RT programs in the state. And what we're thinking of this is something similar to the 2022 Connecticut Health Horizons that helped nursing and social work programs, and really helping assist with tuition incentives for low income and minority students to help enter the respiratory programs, the different respiratory programs, to recruit and retain respiratory faculty. Like all these professions, it's really hard to get respiratory faculty who meet the qualifications needed by our accrediting agency for these positions. And innovative, I think this is a big one, innovative programs to promote partnerships between employers and institutions. Really targeting people who are currently working at hospitals like CNAs and medical assistants to help them get further degrees, and maybe not even in respiratory, maybe in radiology technology. I think this is an area where we could really focus as this task force. So that's kind of the grant money. Encouraging RT internship programs, and Sajad can talk about that because he's had great experience with that.
So encouraging RT internship programs and partnership programs. I know as of Hartford Hospital started an internship program, I believe, last year, and this year already seeing the benefits of that. We have our largest incoming class of respiratory therapists. 9 new graduates are starting in this month, actually. Whereas before, previous incoming classes have been limited to maybe 3, max of 5 new hires. So almost double that already after 1 year. And it helps cut down on their onboarding time because they're already familiar with the hospital. They're familiar with the nursing staff, the other RT staff. It's a very good way to onboard new hires before they actually get hired.
Yep. And then grant retention bonus for full-time work for a certain amount of years. And that's really aimed to try to keep respiratory therapists in the state and not leave the state. And then just trying to get people aware of the profession, where this is very unique to respiratory. unless someone knows, we find that unless high school students know somebody who is a respiratory therapist who had medical issues that required respiratory therapy, they don't know, a lot of people don't know about it. So maybe some funding. These were some ideas from our state organization, billboards, radio ads. And then one of the last thing is support for the compact licensure, so that, you know, maybe somebody who's in Massachusetts might want to work in Connecticut or some of the surrounding states. Thank you.
Thank you, Karen and Sajad. You did a great job, and you actually did your work for the next meeting, so you're way ahead of the team. So thank you for getting us started on that conversation, because a lot of those things do apply to the rest of the professions that we're talking about. Okay, so next on the agenda, and there may be some information that was not able to be received, and that's fine. So if I can hand it over to Paul Kidwell and Dr. Farquhar, who is stepping in for Dr. K. Is there anything that you can share about vacancy rates that you would be able to report out on?
Sure, and it's incomplete today, but we can complete it in our next work. But we surveyed all of our hospital members, so the 27 acute care hospitals across the state, and asked for the following vacancy rate and total FTEs for respiratory therapists, nuclear medicine technologists, and radiological technologists. So at least on the rad tech, a bit of a broader bucket than specificity. We're still running down some absent responses, and so I don't want to give you a full report today, but I can say that the initial numbers confirm, I think, all of your experiences and what you just described. In rad tech, we see vacancy rates of anywhere from 15% to near 50%. Nuclear technologists, you know, in some instances up beyond 50%, some lower, but it seems a more specialized skill set. Not every hospital has, you know, a large number of those positions. So the N is equal to sort of a smaller number there. Respiratory therapists, again, on the low end in the 10s to 15%, on the high ends into the 60s percent, depending on. So what I do need to do is continue to get some additional answers from other members, and then as you probably know, we do need to scale for size, right? So you know, certainly Yale New Haven Hospital's response is different than, say, Day Kimball's response, and the impact of the percentages, you know, has obviously a varying impact on the organization based on its size. So so we'll report, we'll put that in a one place for you all to see, but I think our initial responses, it confirms certainly that we have a lot of open positions across the state. And I think, I don't know if it was you, Bernadette, who showed if you graduate, you find employment. I think these numbers corroborate that certainly, and it's finding a number of individuals that we're struggling to do.
Thank you. Thank you very much. Dr. Farquhar, do you have something you can add for us?
Yeah, so we're still kind of in the data gathering phase. We had sent out a survey. This is going to go to the radiology group outpatient practices. I expected to see data that tracks just what we're seeing for everything else. And I did want to underscore one of Paul's points, which is even though the magnitude of, say, a 50% shortage rate at Day Kimball would be different from Yale New Haven, because I've actually been on professional staff both places, the impact can almost be even worse at the smaller places, because it means entire, you know, days or weeks where you just completely lose a service. And so we see gaps in specific subspecialties of rad techs, whether it be mammo or sonography or nuke med, having very profound you know, patient care delays and impacts because of that.
Yeah, absolutely. You bring up a very good point. We had discussed that at our last meeting about how the shortages are not only causing the burnout to the professionals, but the delays of care to our patients. I think that really is what is at the heart of what this task force is about, addressing the shortage, because we need to bring the care to the people in a timely manner. So the reports are out. Yes, go ahead, Representative McCarthy-Bay.
Thank you, Bernadette. And as I mentioned to you via email, I do not have information to share today, and we'll bring it back to the next time. But one of the questions I have when I think about the information that was just shared is, what is the change in that vacancy rate? I think about that in particular post-COVID. You know, I think about respiratory therapists. Is it significantly larger, the vacancy rate, than it was, say, 5 years ago? I'm assuming yes, but that's something, kind of that growing trend when we saw some of those trend lines earlier. So that's just a question.
Yeah, and I think that's a question we've asked too, right? So it's a complicated question because a lot of things have happened at the same time. You know, we have people retiring because of that age, right? We knew prior, let me say it this way, we knew prior to COVID that we were going to have a problem. We've been saying this for many years, that there's going to be a problem. I think it got a little worse after COVID, and that's partly because technology has increased. And we have more technology, more services needed. We need more respiratory therapists, especially ECMO in the state of Connecticut, which is a good thing. But it's, you know, it's added to the increased amount of total respiratory therapists needed. And I think also burnout was an issue after COVID. So I think it's complicated and it's hard to really narrow down just how much was affected by COVID, but it was all those factors that I put up. And I don't feel like it's going to get better. It doesn't look like it's going to get better in the next couple of years. It's only going to get worse. So whether or not did COVID impact it, it might have, but I don't think it's going to make a change. I don't think it's going to level out in a couple of years. That shortage is here to stay unless we make some changes.
Madam Chair, may I follow up?
You may.
Thank you. I wish I didn't know what an ECMO machine was, but I learned about that this year in my own personal family. I wonder, and I know, in fact, from talking with Senator Summers, but I want to clarify, who is able to woman, man, person, the ECMO machine in Connecticut? How does statute currently reflect who is able to do that?
Yeah, I'm not. I mean, so I'm an ECMO specialist. I was part of the first team in the state of Connecticut to be allowed to cross-train in that way. So at least the stipulations for Harvard Hospital are you need to have your higher level certification, so your RRT. You also need to have your adult critical care credential, which is obtained a minimum of 1 year after you get your RRT. And then Harvard Hospital offers a cross-training program. I believe it's around 2 months of classroom and bedside shadowing. And then you have to pass the test, both written and simulation. And then you can be at the bedside as an ECMO specialist.
Thank you. That's helpful. And I appreciate the context and all of the answers.
Thank you. So I think we've opened up discussion. So we've gone over quite a bit about the background. Dr. Farquhar, yes, go ahead.
I had just a quick question, and it was mostly regarding the rad tech data, Nuke Med as well, on the, I guess, attrition rates or completion rates, whichever way you wanted to look at it. I've heard it from other medical schools other than my own, but it was almost jokingly said that once they let you into medical school, they don't let you leave or fail out. That basically, they say, you know, it's so competitive to get in, similar to rad tech programs where they turn away a lot of qualified applicants. Do we know from any of those programs why it is that folks are dropping out, whether it's a lack of an enthusiasm, they didn't know what they were signing up for, is it financial access? That to me is an area where obviously they have the spots we'd want to, and applicants are, I don't want to say taking a spot, but they're filling a spot not to complete it, to make getting everyone through as close to 100%.
Yeah, that's a great question. I can tell you from our personal experience from our own programs, some of the students that come in do not know what they're getting into. So they realize what the field is once they're in the clinical portion, and at that point, it becomes something that they don't feel as though they can pursue any longer. It's also the training itself is difficult. So we do have, grade requirements that they have to meet and GPA requirements, and we do a lot of remediation, but there's only so much remediation that can be done. Matthew, do you have anything before I get to Senator? Do you have anything that you'd like to add?
No, I don't have any information why, but yeah, doing the research, the 44% graduation rate over 3 years at the only program at the nuke med level is concerning. You're not producing, and there's no fail safe. There's no other programs to help, produce those nuke med techs. As far as why that's such a low rate compared to the other rad techs, even though their low is, not great as well, I don't know.
Thank you. Representative McCarthy-Vahey.
Thank you very much, Madam Chair, and I thank you, Dr. Farquhar, for the question, because I wondered that same thing as well, and if it was worth us having some conversations with a few of the institutions to find out what they know, and certainly with the rad tech, the numbers were very different at different institutions, and it would be helpful and interesting to learn why. Exactly to your point, are there financial pieces? Is it the course load itself? Is it training? What in particular are they facing there? Thank you.
Thank you. I think it's a combination of all of the above, with financial being an incentive that we should probably look towards as a solution, possibly in the future for what this task force would like to address. Any other discussion points about the information that has been brought forward? Dr. Farquhar?
Sorry, me again, but similarly, so finance would be one thing, but the comment about internships or being able to do a preceptorship, similar to what RRT was talking about, those became much tougher to do with COVID. They didn't want extra people in the hospital and stuff. So, I mean, I think those are opportunities, and the state may be able to find ways to get people to do that kind of thing, life in the day of sorts of things, so people know what they're interested in. And that can also have benefits for the individual hospitals, as was mentioned, to get folks able to, who know the hospital, like working there, and then want to stay later. So that may be another way to increase that.
Sure, there are, especially with rad tech, with the 8 programs, there's a lot of competition for clinical spots. And with that, it's not just simply getting the clinical spot, it's having the qualified individual with the right amount of education to oversee that individual who's training. And it's the amount of machines. So it becomes this trickle effect where, yes, we would love to be able to train as many people as we can. Our capacity, for example, Quinnipiac's capacity is 96. Well, that would be ideal if we could put that out, but it's not a realistic number with the competition that we have in the state.
And at the hospitals, right? So the aperture has definitely widened since COVID. It certainly got very small when, at least in nursing, we're considering or thinking about off hours shifts and things that we wouldn't normally have considered prior, but using all available hours in a day to do the teaching. That is not always appealing to everyone, just given normal sleep schedules. But we're trying to identify how can we use all the available hours to do the clinic, and also thinking about outside of the hospital and outpatient settings. Are there opportunities to basically do the same thing in an outpatient setting? I think opportunities there where we haven't sort of explored them prior and now are doing that to see if there's some additional space there.
I think we're hitting a lot of the points for solutions and that Karen and Sajad had brought up with how what can we do? What can we do to address the shortages? So I think that we have a really good foundation for where we are. Hopefully we can get more information about the numbers for the vacancies in the state in both outpatient and hospital locations. That would give us a better idea of how many techs, if we're graduating 153, right? So if we're graduating 153 rad techs per year, where are they going? I think retention is something that we need to think about. So how do we get these techs to stay in the state? So how do we get them to stay in Connecticut? And that's huge. So what are the employers doing in order to keep them satisfied, keep them happy? They have them for 2 years training, right? So most of the time, all of our professions take 2 years. So you have somebody for a semester, you have them for so many weeks. What are you doing to entice them? How can we get them to stay? So I think those are the things that this task force should think about and how we can put that word out there. Matthew, I'm going to ask if there's anything that you'd like to. Oh, sure. You want to follow up?
Item for one of the things that it may be interested to learn more from the colleges and universities is post-COVID, healthcare is competing with employers that we weren't used to competing with before for talent. And one of the things, as I thought about the open placements in the across the state, is where are those students choosing to go instead, and or outside the university or college setting? What are the employment opportunities that people are pursuing? To Representative McCarthy-Vahey's point, sort of pre-COVID versus post-COVID, and where in that and not just in this context, but in other contexts too, that has vexed me for a year and a half, trying to think about where are the pipelines all going, and people are going somewhere because we have a fairly low unemployment rate. So people are, where are they going, and how do we make, and it's, in a state where we're incenting manufacturing jobs and incenting new biotech jobs and incenting healthcare jobs, and there's only so many people. So, our charge is to make sure we get people into these positions, but I don't know if the universities or colleges have some special insight. I'd be interested in hearing from them.
Sure. I think that's going to be that will be something that we're going to ask. I think next meeting, we're going to ask program directors to come forward and have a report out as to their experiences. I know, Sajad, you want to say, you would like to say something?
I was just going to say, at least for respiratory therapy, the trend that I've noticed, and thankfully it's decreasing, was that new hires were coming into hospital positions for about a year or so to get initial onboard training, and then transitioning to getting hired by a travel agency, because you need a minimum amount of experience, because those travel agencies offered higher pay, maybe better financial incentives. That seemed to be the case since 2020. It does seem, at least for respiratory, from my personal experience, that seems to be decreasing. More and more new graduates are now staying with their initial primary hospital because financial incentives are either worse at the travel agency or better at their primary hospital.
Yeah, I think I can agree with that. And I think, Paul, to address the question about, what's happening with these students, where are they going? I think a lot of it has to do with the fact that we're training a different student. The student is very different than it was pre-COVID. So we have a very different person that we're training. So I think we need to take that into consideration as to their experience before college to coming into college or coming into training for a profession. So I think those are things that many of the schools are addressing right now, how to get these students to stay and to have them properly trained to address, professions such as nuke med, rad tech, or respiratory care. Yes, Representative McCarthy-Vahey.
would defer to Karen, since I have spoken so many times, and happy to speak after her.
Okay, Karen.
Oh, just a suggestion, we talked about like HOSA and really tapping in. Maybe this is an opportunity, what you're addressing now, students aren't really prepared, and I'm seeing that too, and I've heard that from other educators, because it is different. Like education right now is a little bit different post-COVID. Maybe that is an opportunity to hit to really address the high school students and give them opportunities for touring hospitals, for doing some shadow, for going to different colleges, maybe connecting with HOSA and having the different healthcare universities, colleges, let them come in and see firsthand some of the education programs, or some of the hospitals letting students, I don't know how easy that would be, but letting students come in and see. Maybe that would help to better prepare our students so they know what they're getting into.
Thank you. Senator McCarthy-Vahey.
Thank you. So I just wondered if you could say a little bit more about what you mean that we're educating a different student. I know there's been a lot of conversation around that in other places, but specific to these groups that we're talking about. Can you just say a little bit more about that?
Sure. I can talk to the students that are entering in now. They were in online courses. So they were in their high school career online. So a lot of what they didn't have to have their camera on. They weren't held to the same standards. They were able to submit their work when they wanted to submit. And then they enter into college and it's a different game. It's a different, ball game. Now they're held to different responsibilities. They've got time. They have to come in on time. They have to submit things on time, and they have to communicate. So speaking is also, talking to somebody is very different than chatting in a box on Zoom and I think that's what we're running into. There's a lot of anxiety with students these days. Karen.
Absolutely. I agree with everything Bernadette just said. And, add on, you alluded to this a little bit. These students have gone through a pandemic at a fragile age. Right now, there's a lot of mental health issues. There's a lot of hand-holding. I know Bernadette talked about a lot of remediation. We have never done so much remediation. It takes a lot of faculty time. There's so much more we have to spend, and I think everyone that's educators in here can probably shake their head and agree with this. We have to spend so much more time helping these students become successful. I'm really proud. I don't know if you guys noticed our attrition rate is very, very good, but I'm really proud of it, but it was not without a lot of work. And I know every program director in the state, and they have done the same thing. It's not just respiratory, it's across the board, every program. So it's a lot of mental health issues. A lot of students are really probably not coming prepared because of the online classes. So I think that's kind of the different student.
May I just say thank you for the responses and just naming those things out loud, because that takes time, resources, and funding. And
Yes.
That's also a part of this. And we hope that as the cohorts of students who have been back in the classroom, that will continue to shift. Although, and the issues around the anxiety, I think, are something that are part of the collective trauma that many have experienced. So I thank you for naming those things out loud.
Thank you.
And I think as a hiring manager, we see the trickle down effect of that we're seeing a different entry level workforce. We go back to that. You go to school and you get out and you get your 40-hour job and you go into the grind, and we're not seeing that. We're having difficulty filling full-time positions. We're breaking up positions. Their workforce is, living at home longer. They have health insurance through their parents for a longer time. That we break up jobs all the time to make 20-hour positions, 24-hour positions just to get them in the door, but it's still not filling our void. And then when hours are created, we offer them to these people that we have part-time, and they decline it. So you're just dealing with a different, at that age and where they're coming out, it's a different workforce we're seeing as well, not just a different student.
Yeah, thank you, Matthew. I think that's also something like, what can we do? What can we do to entice them to want to work more?
And may I just add, I know I apologize, I keep adding things, but to Paul's point earlier around the unemployment rate, which is, the competition is fiercer at this point in terms of other potential positions too. So it's I think Karen, you had on your slides, the marketing and all the other ideas, which I know we'll get to more.
Thank you. Yes, and so that is our task for the next meeting, is to come up with more of those ideas that Karen and Sajad already got us started with. So I think they've got a head start, which is okay. So Matthew and I have some work to do. And then we appreciate the support from Dr. Farquhar, Dr. Kay, Paul, and Senator McCarthy-Vey for your input as well. Any other thoughts or anything else that anyone would like to add to today's meeting? Okay, so hearing none, I am going to just ask if there is, for moving forward. So I will ask Matthew, Karen, Sajad, if we can gather, including myself, gather program directors to be able to see who's willing to be able to come as a guest to our next meeting, to be determined in September. So the plan is to have a meeting in September. That's our next meeting. So that would be to hear from the program directors from the state, from the various professions. Maybe have an update from vacancy by that time, as well as discuss any other state actions that could hold promise in attracting people, especially to respiratory care. So HOSA is a great idea. What other things can we do to entice our to fill our areas, to fill those positions? There are some ideas I can tell you, for instance, in my profession, remote scanning is a possibility. I don't know, Dr. Farquhar, you have heard about that? So remote scanning, I say scaring because it is scary. So remote scanning is something that is out there as a way of one person being able to do several different scans at a site. So no patient contact. They're just scanning. So that is a possibility, and that will help with throughput, but at what cost? So those are things I think that we can think about. But the problem is we need to get people in. We need to fill these vacancies. We need to get care to the people in it again. Yes, go ahead.
Yes, me again. Just in terms of thinking about who we could also talk with, the Office of Workforce Strategy. I think about them if we've had some nursing task forces, and so while of course not exactly the same, some very similar questions, and there may be some insights and folks there who could share some of the learnings through that process with us. And also think about Jen Widness with CCIC, to again has worked very closely with that office in terms of maybe not be at the program director level, but maybe also able to gather and help us get some of those program directors and gather information through that way as well.
Thank you. Karen.
Sorry. So I can definitely reach out to the program directors in the state of Connecticut. I'm just wondering, do we want all of them? Is that going to be too much for this meeting? Do you want me to give us specific questions that we're going to ask them so they come prepared?
I would think so. I think maybe we should come up with some questions to ask and then address it to them and then summarize their results, perhaps, but get their
And we're
feedback.
saying all of them, as many as we can get, we would like.
I believe so.
Okay.
Yes. Anybody have any thoughts on that? No. Okay.
It's not a
No.
huge universe. I mean, it's so I think it's good to, and it's likely corroborated across, but it might be interesting to hear the variation to the extent someone is doing something that they think should be practiced across the state. It would be interesting to hear where there's successes.
Thank you.
And I should say, we're reaching out to hospital associations across the country to see what might be working in other states as well. So hopefully we'll bring that back.
Okay, wonderful, thank you. All right, are there any other thoughts, any other comments or questions? Do I have
Thanks
a
for
motion?
hosting such wonderful meetings. Thank you for organizing this. I really appreciate it.
Thank you, Paul. Do I have a motion to adjourn?
Moves.
Okay, second by Karen, perfect. All right, thank you. Please stay tuned for a link coming from us about a meeting request again. So I appreciate it. We're looking towards September. So I will put a few dates out there and hopefully mid to end. We'll stay away from the holiday, so mid to end, okay? All right, thank you, everyone. Have a great day.
Thank you.